Good afternoon. My name is Richard Aplenc, and I'd like to thank the organizers of the committee very much for inviting me to give a talk at your wonderful meeting. I'm very sorry that I can't be there in person, and I hope that I'll be able to join in person in the future. I'll be talking today about cardiac toxicity in pediatric acute myeloid leukemia. Since this is a recorded presentation, I won't be able to take questions in the context of the presentation, but certainly please feel free to reach out to me if you have any questions afterwards. I'd be very glad to try to answer them. So we have two learning objectives for today's talk. The first is to review the data regarding anthracycline-associated cardiac toxicity in pediatric acute myeloid leukemia, and the second is to review the data supporting the use of desorexizoxane for cardioprotection in the pediatric AML setting. So I'd like to start with a little bit of background about pediatric AML chemotherapy. This will be very familiar to many of you, but in the chance that there may be some people who may not be so familiar with AML, I thought it would be helpful to do a brief review. First of all, there are two cycles of anthracycline-based chemotherapy that start AML chemotherapy, and then there is consolidation afterwards, and the consolidation is determined by cytogenetic and molecular features as well as disease response. Consolidation therapy often relies on high-dose cytarabine with additional anthracycline in some cases, or stem cell transplantation. And as you probably know, there's a wide range of transplant conditioning regimens as well as donor type and stem cell source, and we won't be speaking about those today. This is a summary slide showing pediatric AML dose intensity across multiple clinical protocols. I think what's important here to take away for this talk is that the anthracycline exposure is very close to the maximum cumulative anthracycline exposure that we think is appropriate for children. Certainly the studies that we'll be talking about, and the data from those studies, are at exposures of over 400 milligrams per meter squared, which are on the high end, but certainly well within the range of anthracycline exposure that many children receive around the world. I think the other large point to take away is that AML chemotherapy is harder than an autologous stem cell transplant, but easier than an unrelated donor transplant. And I think for me, this helps organize my thinking around the risks of toxicity and the severity of toxicities. So this is a slide that summarizes some pediatric AML historical outcomes across multiple cooperative groups. And what you can see here is that on these historical data, event-free survival is in the 50 to 60% range, and overall survival is in the 60 to 70% range. There are some newer data, particularly from the European groups, that may have a higher event-free survival, but at least in the US, we're still looking at about 50 to 60% EFS and an overall survival of 60 to 70%. Now, you will be very well familiar with the fact that pediatric patients who receive AML therapy are at risk for cardiac toxicity, and I think I previously mentioned the cumulative lifetime exposure. We know very well that late cardiac toxicity is a leading cause of morbidity and mortality in children who survive pediatric AML. But the contribution of early cardiac toxicity, either on therapy or immediately after therapy, has been not recognized, or at least not quantified for as long a time. And those really will be the data that I'm presenting. Here it's important to note that we think there are really two different types of early cardiac toxicity, one which is associated with infections and the other which is not. And in our data that we'll present, we'll show a breakout by those two groups. And currently, the Children's Oncology Group mandates desorexizoxane as standard of care in all anthracycline courses that are not liposomal formulations. And we'll talk about those data. Now, the data that we're going to talk about come from two clinical trials. The first one is the AAML 0531 trial, which we sometimes refer to as 0531. And the second trial is the AML 1031 trial, which we sometimes refer to as 1031. 0531 randomized patients to gemtuzumab with or without standard chemotherapy, and we got echocardiograms after cycles 1, 3, and 5, and we collected adverse events in about 1,000 echocardiograms. On the 1031 trial, we randomized patients to standard chemotherapy with or without bortezomib. Importantly, this standard chemotherapy had one course less than the 0531 trial, but that was not an anthracycline-containing course. So the anthracycline exposure in these two trials is essentially identical. Here, we did require echocardiograms after every cycle, not just cycles 1, 3, and 5. And in addition to collecting adverse events, we also asked sites to report an ejection fraction and a shortening fraction number after every cycle of chemotherapy. And so we were looking for cardiac side effects differently on those two trials, and that's really important to bear in mind as we go forward. The fact that we asked sites to look for cardiac toxicity differently resulted in different compliance with echocardiograms. So on the left hand, you can see on AML 1031, we had almost greater than 90% echo compliance after every cycle of chemotherapy where we recommended or required an echo. And that means that we have an ejection fraction and shortening fraction after every one of those cycles. On the 0531 trial, however, we only required echoes after cycles 1, induction 1, intensification 1, and intensification 3. And as you can see, the compliance for the echocardiograms dropped off very substantially. So for example, in induction 2, on 1031, 9 out of 10 children, or 90%, had an echo to look for cardiac function. On the 0531 trial, only 46% of children had an echo, so less than 50% of children had an echo after the second cycle in 0531. It's very important to remember that we're looking differently for cardiac toxicity. So these are data that were published in 2019 in the Journal of Clinical Oncology that showed that patients who had infection or non-infection cardiac toxicity had a significantly decreased event-free survival, and you can see the rates there. So for patients who didn't have any left ventricular systolic dysfunction, their EFS was 50%. But patients who had infection or non-infection associated LVSD, their event-free survival was 32 or 36%, so substantially different. And this difference in event-free survival translated into a difference in overall survival for patients without infection-associated cardiac toxicity. So specifically, patients who had no left ventricular systolic dysfunction had a 5-year overall survival of 66%. However, the patients who did have non-infection-associated left ventricular systolic dysfunction had a 5-year overall survival of 45%. So an absolute 20% difference in survival based on the occurrence of cardiac toxicity that was not associated with infection. This is a magnitude of impact that is larger than the benefit of gemtuzumab that was seen on this trial. And it's a very, obviously 20% is a very substantial difference. So based on these data, we concluded that actually there was clinically impactful on-protocol toxicity, and that this toxicity affected both event-free and overall survival in the setting of infections, for event-free survival, but only impacted overall survival in the setting of non-infection-associated cardiac toxicity. And these data for us really indicated that we needed to do further studies to really examine carefully the patients who we had not gotten echocardiograms on in the second cycle and in the fourth cycle. And so this takes us back to the slide that I showed you previously for the 1031, where we see that we have 9 out of 10 patients on average getting echoes after the first 4 cycles of chemotherapy. Now with those data, which include actually a numerical ejection and shortening fraction, we determined the prevalence of grade 2 or higher left ventricular systolic dysfunction. And what you can see here is that it's twice as high as the same outcome defined on 0531. So on 1031, that overall incidence is 22%, and on 0531, it's 12.1%. Now again, this is essentially exactly the same chemotherapy. The only difference is that we're looking more frequently. And I think that is very important as we think about what these data mean for the care of our patients. Specifically, if we don't look for cardiac toxicity, we won't find it. And you can see below in the second part of the table, the course-specific prevalence that across all courses, there was a higher incidence of cardiac toxicity on 1031 than 0531, again, given essentially the same anthracycline exposure. Now, because we collected ejection fraction and shortening fraction after every cycle, we can actually trend those over time for this trial. And when we look at the full population, and this is the figure on your left, you'll see that, excuse me, the ejection fraction starts at about 67% and then trends down, increases slowly between at the end of therapy and about 1.5 years after therapy, and then begins to trend down again. And this is really important data because this is really, to our knowledge, the first really longitudinal description of what happens to cardiac function in a large number of patients receiving AML chemotherapy. And on the right-hand panel, you can see the trajectories for patients who have cardiac dysfunction and who don't. And here, although the drops are much steeper for patients who have cardiac dysfunction, as you would expect, they both have the same trend, which is that they gradually decrease over time, increase, and then begin to decrease again. We're also able to look at trends by age and by randomized arm and by gender. And when we look by age, we actually see that infants who are 0 to 1 years of age, there in the blue line, they actually have less of a drop in their cardiac function than older children. And this is actually very different than what you would see in the survivorship data, where the younger children actually have higher risks of cardiac dysfunction in the long-term setting. And we think that's actually because of survivor bias, that they're the patients who are actually surviving that long, and therefore they're the ones who then are presenting with more frequently with cardiac dysfunction and late follow-up. You can also see that there was a difference in the rates of cardiac toxicity between the bortezomib and non-bortezomib arms. This was mainly related to infection, but important obviously for the trial. And finally, for reasons we don't understand it, it appears that females have a greater drop in cardiac dysfunction than males. Now here are the event-free survival curves for 1031, and what you see here is actually really interesting, that the patients with infection-associated cardiac dysfunction actually have a slightly higher overall survival than patients without any cardiac dysfunction, and that's not something we understand. But the rate of the event-free survival for patients who have non-infection-associated cardiac toxicity is 38%, which is substantially less than was in either of the other two groups, and very, very similar to what we saw on the 0531 trial. Likewise, for overall survival, we see almost exactly the same results on 0531, where there is no difference between infection-associated cardiac dysfunction and no cardiac dysfunction in terms of overall survival. But the grade 2 left ventricular systolic dysfunction patients who didn't have that in the context of infection have a significantly decreased survival, which again is about 20%. So 66 versus 49, almost 20%. So very similar in magnitude of effect as we saw in the prior study. So for us, our conclusions are that in this separate data set with better or more comprehensive monitoring, let's say, we saw again clinically impactful on protocol cardiac toxicity. And this toxicity is again associated with overall survival in patients who do not have that cardiac toxicity, excuse me, in the context of an infection. And we also saw some subtleties to the data that we did not see when we were monitoring less completely. And we also noticed that the overall survival for patients who had any cardiac toxicity was improved, and we wonder whether that may be due to the fact that early monitoring detects the toxicity later, which allows us to intervene sooner, and that may help improve the overall survival. That's not yet a proven hypothesis, but one that we're working on understanding actively right now. So finally, I'd like to present some data about desrisoxane. And so this is the study design, and you can see on the left-hand side, we had all patients with without a FLT3 ITD mutation, and we separated those into patients who never were exposed to desrisoxane. Those are the 918 patients in the middle box at the lower part of your screen, and 173 patients who got desrisoxane at some point in frontline therapy. Of those 173 patients, there were 78 who got desrisoxane at some point during therapy, but not in every cycle, and we eliminated those patients and instead focused on the 95 patients in the blue box who received desrisoxane in every anthracycline-containing course. And then we compared these two groups of patients, specifically the 918 who never received desrisoxane and the 98 who received it in every cycle. And when we do that, we see that the overall incidence in this group of patients, subset of patients on 1031, was about 19.5% for left ventricular systolic dysfunction. Again, importantly on 0531, it was 8%, and that again is because we're monitoring more carefully. But when we look at the rates of cardiac dysfunction by desrisoxane exposure, we see that they're dramatically different. So it's 8.1% in the patients who received desrisoxane and 20.7% in the patients who didn't, and that's statistically very significant. And you can see that comparison here circled in red with the arrow. This difference in rate of left ventricular systolic dysfunction held true in every cycle of chemotherapy. So you can see below that in general, the rate of cardiac dysfunction is about half in the desrisoxane exposed patients in every cycle than in the desrisoxane not exposed patients. And then we obviously looked at the impact of desrisoxane on survival, because the concern here is that if we protect the heart with desrisoxane, we'll actually protect the leukemia, and that will translate into a greater risk of relapses. The panel on the left-hand side of your screen shows that there is actually no difference in event-free survival between patients who got desrisoxane and patients who didn't. The desrisoxane-exposed patients had an event-free survival of 49%, which was a little bit higher than the 45% of the never exposed, although that was not statistically significant. And when we look at treatment-related mortality, we see a difference of 5.7% versus 12.7% that approaches but doesn't reach statistical significance. And so, this is some data suggesting really that desrisoxane may prevent cardiac-associated mortality in the context of the AML setting. So in our conclusions for desrisoxane, we thought that desrisoxane is associated with a statistically and clinically significant improvement in cardiac function, that there is no impact on event-free survival, but desrisoxane may decrease treatment-related mortality. And so these data for us strongly suggest that patients should receive desrisoxane in all anthracycline-containing cycles in AML therapy where the anthracycline that is being used is not a liposomal formulation, and that is now the standard of care in the Children's Oncology Group. So with that, I'd like to thank you very much for attending this session. Certainly look forward to any questions that you might have offline, and would like to thank all of my collaborators, particularly Kelly Getz, who drove forward many of these analyses and extraordinary data collection, as well as, of course, everybody on the AML 0531 and 1031 study teams, and the patients and the individuals that have supported us. Thank you very much.